really enjoy the topic, and I hope we get some good, lively discussion today. Moving into the discussion, I thought as we talk about the evolution of medical staff models, it's probably a good opportunity for us to move back to the original drivers, if you will, for hospital medicine opportunities. And while they're varied and may be more significant for one hospital than the other, I'd say certainly for Lodi Memorial, the demand from other providers to move to a hospital medicine model format was significant in our community, not only with the assistance of co-management of patients, but primarily the opportunity for preferences in the community practice, the opportunity to more efficiently manage their own internal practice, and therefore giving them opportunity to hand off that hospitalized patient to the hospital medicine program. That was probably one of our largest drivers for enhancing the hospital medicine program here. But of course, have to absolutely add the focus on quality and patient safety, the ability for hospital medicine to grasp the initiatives that the organization is driving towards, both in quality or safety, is extremely large and much more difficult when you're dealing with a significant number of community providers. And along those lines, perhaps not as obvious initially when we were anticipating hospital medicine expanding, however, a strong value to the program has been the hospital-based initiatives, whether electronic health records or other opportunities either on the cost side or quality side. Certainly the hospital medicine program have been extremely helpful and drivers as it comes to exploring and optimizing some of those initiatives. So certainly, while a lot of these can be open for discussion as far as prioritization, I think these are primary keys for us for the hospital medicine program. Unfortunately, the hospital medicine program has brought some amount of what we would call unintended consequences, and unfortunately, in some cases, significant consequences. Certainly, we've seen provider passive separation from the hospital. So whether that simply means the community physicians opting off of medical staff committees or minimizing their leadership participation in some fashion, we've certainly seen that passive separation as our medical staff departments start to dwindle within the hospital. Perhaps a little bit less significant, however important, is more of an active separation. And we've seen some direct competition from those physicians that we're enhancing with the hospital medicine program to actually entering into competition with the organization. Perhaps the most significant factor that we've seen as an unintended consequence is a bit of disillusion with the hospital change. As we try to define what this new medical staff model will look like, what we do have are well-meaning leaders within the physician community who have recognized this change that's happening in front of them, and unfortunately are grasping at how to continue in their previous leadership roles, and yet their own practice has changed as well. So certainly significant consequences, all of those driving down to a significant change in focus within our hospital medical staff departments. That focus moving more towards, hopefully more towards education. However, just the participation is a concern for us, as we certainly recognize that we need to maintain that community provider within our framework of our hospital leadership. Jason, any comments on these two slides?
No, thanks, Mark. I think a lot of what we're seeing just in general movement beyond just the scope of hospital medicine is that there's been a change in the way that hospitals operate. Physicians are moving towards a predominantly inpatient setting and then predominantly outpatient setting. And I think that all those, that shift in terms of physician practice styles and the way specialties are moving, and even specialties that we thought that were predominantly hospital-based, surgeons, gastroenterology, they, with the advent of surgical centers, even that's moved towards a largely outpatient arena. So I think that some of the ways in which people are practicing medicine in the world, in the country, have really shifted toward this kind of in or out type model, and it's been driving a lot of these things.
Absolutely.
So medical staff bylaws, always a terribly exciting topic. In one of my former roles, I was a chief medical officer of a community hospital, and I spent a lot of time reading them. And I think that one of the things that we're seeing now is that medical staff bylaws have had difficulty staying abreast of what's really changing quite rapidly in the medical staff models that exist in the world today. As there's been this real movement towards inpatient and outpatient, the bylaws are often, old and somewhat complicated and a little challenging to change. And what we're seeing is that there's a disconnect between how the medical staff is put together by means of their bylaws and how they're actually operating, how they need to operate in today's healthcare environment. And changing or altering those bylaws is really challenging. It often takes a lot of effort, takes legal involvement, and there's expense with it. And it does lead to some inconsistencies and a lack of synchronization between the practice patterns that we're actually seeing at the hospital and what we're actually supposed to be doing according to the bylaws. And so not to make it to be a huge deal, but I think that they need to adopt to how practices are occurring today in 2012. And I do think that the way that the things are written and the way that the staff bylaws are existing are putting a lot of demands on what the new medical staff, as we'll call them, which are predominantly the inpatient providers, which are largely hospitalists, emergency department physicians, usually some radiologists, and some surgical docs that are in and out. But there's usually a lot of time demand that in the former medical staff models was distributed amongst a large group of community physicians. But as those physicians either don't spend time in the hospital or spend less time in the hospital or may not even be affiliated with the hospital, the amount of work that was delegated out, such as credentialing, quality assurance, med exec meetings, all these things, they still need to be filled. And so it's putting a lot more time demands on the providers that are currently in the hospital, which we're seeing a lot in hospital medicine programs in terms of they're already very busy with clinical work, but then they're trying to meet all these other obligations. And then I don't think we could really talk about much if we didn't talk about the role of electronic medical records in hospitals today. They are, I think, tremendous time sinks. I mean, I think that they add value, but they definitely take a lot of time and really a lot of input from the providers on the ground. And so just the implementation of electronic medical records and health records in the midst of all this change has put a lot more time demands on the new medical staff. Staff categories are something I'll mention again in a few minutes, but again, that's just figuring out how best to maintain that relationship between the inpatient and outpatient docs, the docs that have been at a hospital for 20 or 30 years, and then the newer physicians, and what's the right category and how to put those together. I think it's important to start to think about how they work and how we're going to keep outpatient docs involved with the inpatient arena and make sure that there's good communication. And then finally, I think maybe, Mark, you can comment about this, but I think we really have to think about making sure that the way that the physician staff is operating in a hospital, whether it's the traditional medical staff or whether it's an employed hospitals group, that there is synchronization between how the physician practice operates and how the hospital is operating, because we fundamentally need each other. A hospitalist without a hospital is a chip problem, and so we need to make sure that we're all on the same page and working in the same general direction.
On the same page, same direction, and hopefully with a plan. And unfortunately, I think certainly at Lodi, I would say that we underestimated the significant change in the medical staff leadership. And I think we're just getting back on board with revisions that are necessary to really bring the right medical leadership to the organization. So absolutely correct, maintaining that synchronization. So Meredith, I think we have a polling question next.
Great. So I'm going to launch a poll, everyone. Give me one moment. The question is, do your medical staff bylaws have a staff category for outpatient-only providers? Please select yes, no, currently developing a new category, or unsure. Just a few more seconds to get your answers in. Okay, and the results are 26% said yes, 37% said no, 3% said currently developing a new category, and 34% said unsure.
Thank you, Meredith. I mean, I think it's very interesting. We're pretty evenly split across this particular topic, but it's something that's come up in a lot of organizations as we move forward to deal with how to keep the community physicians involved. And so it's going to be an interesting debate as we move forward.
And just as Jason said, as we start to look to the future about how we evolve the medical staff, I think one of the comments that Jason's made earlier is maintaining that community provider involvement with the hospital organization is absolutely critical. Unfortunately, one of the early initiatives that Lodi considered here was consolidating medical staff departments in order to drive some efficiencies within the organization. But what we quickly understood was we were failing to recognize continuum of care issues and the importance of our family practice partners out in the community participating from a quality perspective, a care transition perspective. And so we backed off on those original plans and actually trying to, as best we can, assist some of the medical staff departments in envisioning that new future of evaluating outpatient quality of care, as well as effectiveness of care transition programs, minimizing hospital readmissions. And that certainly has been our focus in this new evolution of medical staff models. Certainly those areas are non-traditional for some of our departments, like family practice, but certainly a direction that we're heading in. Does that fit, Jason, in with some of the new staff categories that you're thinking about?
It does. It does. And, we really think about, even when, we had been involved with Project Boost early on, all the work we can do in the hospital, whether it be the ER or the hospitalist intensivist, if we don't make sure that information flows out and the patients get good, solid care in the community, then they're just at risk for readmissions, and we're kind of perpetuating the cycle. And when I talk about the development of new staff categories, I had done some work both at my prior organization and as a consultant. And when people think about categories, there was this real feeling of wanting to make sure that there was close involvement between the outpatient and the inpatient docs, as we talked about. And so one thing that came up was, how do you bring in the outpatient physician to the inpatient community? And so we actually had looked at some organizations of having readmissions, a certain quality, and involving the outpatient docs to do some quality review of the inpatient work, so that they could look at what's being done on the hospital side for any readmission. And so we could get that feedback of, hey, did you look at what's going to happen with this patient when they go here? And so it was really important as we thought about staff categories even though people like to be outside the organization, be outpatient doctors, but to maintain that affiliation. And I say maintain active, and that active term in there was very important, especially as I talked to some members of the medical staff that were, had been in the hospital for a longer time, older generation. It was very important for them to be active members of the medical staff, active part of the hospital, even though they had chosen to be in an office-based setting. And so using terms like active referring, active consulting, or some way of encouraging them to be active parts of the staff, even though they may be outpatient-only practices. So I think it's really important as people start to think about those staff categories, which is not something I think traditionally hospitalists have thought about, but as we said, we're the largest portion of people in the hospitals doing this. We have to start to think about how to incorporate those folks. And that's really about not only staff categories, but maintaining that relationship between inpatient and outpatient providers. It's harder and harder to get to the hospital or to meetings We seem to have lots of meetings, but with the way and the advent of virtual technology, things like a webinar like this. I mean, Mark and I are giving a webinar, and are thousands of miles apart, but we're able to start to work together using things like quarterly meetings instead of monthly meetings, or opportunities for physicians to get together, using newsletters, virtual technology to make sure that both providers on both the inpatient side and the outpatient side are working synchronously together and incorporating what's going on in the hospital, because the outpatient docs need to know that they're referring to an organization that has high quality and has a direction. So making sure that the hospital's visions and goals are all incorporated into that, make sure that the community is working on the same page. Mark, do you have anything to add to that?
No, I absolutely would agree on that relationship between the inpatient and outpatient providers, and unfortunately that some of that passive separation, as you mentioned, is causing or creating that divide, unfortunately. So in any fashion of improved communication to bring those groups together, absolutely paramount to make sure the medical staff model of the future works for us.
Excellent. So just thinking forward a little bit further on how the hospital medicine is going to fit into all this, and there's a lot of questions of, hospitalists maintain a significant portion of the hospital, and are they a department or a division? In other words, are they part of the Department of Medicine? Are they a division of it? Are they their own department? I think a lot of that depends on the size of the program and the number of providers. I think, again, thinking about credentialing and the delineation of privileges, we need to be in sync with the current practice patterns. As certain procedures aren't done as much in the hospital, or just aren't done as much in general. We should probably make sure that our delineation of privileges are in sync with the things that the hospitals are doing. So if the hospital doesn't have the ability to do certain interventional procedures, they probably shouldn't be on the delineation of privileges. And so thinking about, okay, these are the physicians in my practice. These are the physicians in the hospital. These are the things that we're going to ask them to do, and making sure we're being in sync with those, or making sure we're assuring quality with those. And then the one thing that comes up a lot is block scheduling. I think a lot of people enjoy careers as hospitalists because of being able to be in a 7-on, 7-off, or a 5-on, 5-off type model where you work your days and then you're off. But that also does make it somewhat challenging on provider participation. So we'll see a lot of hospitals say, well, this is my 7 days off, and I'm really tired from my 7 days on, so I'm not going to be an active part of it. And we have to be careful as a specialty that we don't split ourselves down the middle and say, oh, we're only here for 7 days, and we're only doing this, and we're not going to do the rest. And it's important to think about the effects of the block scheduling. It's nice on lifestyle, but how we're going to be a part of the hospital. Because that does go to supporting committee work, aligning with hospitals on development, strategic plans, pharmacy and therapeutics. It's just quality. There's so much stuff that needs to be done in the hospital that I think, Mark, from an administrative standpoint, you're looking to, the physicians in your hospitalist group and those to work towards.
Mm-hmm.
And then I'll just touch on this, and then I'll let Mark chime in for a minute, which is, the high cost of turnover. Turnover is a challenge in general. Turnover is a challenge when the C-suite has a change, a new CEO comes in. It's a challenge when a physician leaves, or when there's a turnover in a group. So when someone moves from one employed group to another employed group. So we have to think about how that turnover affects everybody in the hospital. And I think that it is somewhat of, I put quotes on problems, a little bit of a problem for hospital medicine that we have to really be aware of. Turnover and the movement of physicians in and out, or groups changing and such, is just disruptive to how the hospital operates. And I think it's the one criticism that we tend to get a little bit from some of my colleagues that have, had traditional medicine practices where they were inpatient and outpatient, lived in the community, been there for 20 years. When our providers are turning over, I think it does have some trust, and there's some thought. We just have to be careful about how we work through those issues. Mark, do you have anything to add on how that might interface with you from the hospital administration side?
Yeah, well, actually, the whole slide, you're absolutely correct, and we certainly understand particularly the block scheduling format for the hospital medicine program. We certainly recognize the value in continuity for a 5-day or a 7-day stretch, and we appreciate that continuity. However, it doesn't bode well when you're scheduled to be at Pharmacy and Therapeutics Committee, and that's being scheduled on your week off. So you're absolutely correct. It's that balance between how do we provide that medical staff leadership when we're trying to also recognize the preferences for the hospital medicine team to practice in the fashion that they desire to practice. So it certainly is a issue for us. And it somewhat leads to that next slide, and probably more importantly is, so how are we trying to engage that hospital medicine physician into the new leadership roles as best as we can? Are we providing opportunities for them that are of interest to the hospital medicine physician? Are we properly encouraging those levels of interest? We've tried a few different ways of engaging that hospital medicine physician here, whether it's identifying areas of particular interest, specific projects, and trust me, there's, as you well know, there's a multitude of projects that are going on at any one time within the hospital, whether that's with IT-related issues or clinical quality. There's always a project that's going on that really could value from the hospital medicine leadership. We certainly do recognize that varying level of commitment, however, and once again, as I think Jason said, it's somewhat recognizing that the hospital medicine provider is perhaps picturing themselves as providing that service for that period of time that they're scheduled for, and then after that, gee, I've got a family, I've got commitments outside my work area, and we're certainly recognizing and understand that, and it's identifying that that balance, if you will. And you know, I know we've been discussing quite a bit just the evolution of the medical staff leadership model and that evolution, but it's the recognition also that the hospital medicine leadership team, that the hospital medicine physicians are viewed much more from the hospital standpoint than only medical staff leadership. These truly are the chief medical officers for the hospital of tomorrow or of today, or whether it's a vice president of medical affairs position or something. These are the physicians that the hospital is going to turn to and look to bring over into a direct employment in a leadership position for the hospital. So it's not just the hospital medicine team, not just providing leadership to the medical staff, but to the entire organization. And Jason, you know, just on the compensation side, and you may want to comment on here as well, we try as much as possible to provide that balance during their workload, whether that's a workload reduction during medical staff committee participation or whether that's through direct compensation of some type. We're certainly trying to provide that avenue for to make their workload realistic, as well as encourage that leadership opportunity. Any comment there, Jason?
Yeah, exactly. And when we go out from a larger, from being Team Health being a very large, staffing company, hospital medicine management company, and we're in like I think 19 or 20 states now. We go out and we talk to hospitals and say, once you get into this and start doing it, there's a lot of time, and trying to account for the development time and the rest is really important. And so we really like it when we have that conversations with our administrative partners on how to build that to allow the program to be more than just taking care of the patients in the hospital bed, because the programs are really looked at for more than that.
Great. And I think, Meredith, we have another polling question.
Okay, great. I will launch this poll. The question is, hospital medicine physicians fulfilling medical staff leadership responsibilities are a difficult commitment and burdensome. Please select agree, somewhat agree, disagree, or unsure. And just a few more seconds before I close the poll. And the results are 21% say agree, 51% say somewhat agree, 28% disagree, and 0% are unsure.
Wow.
I think that just comes, I think when I look at those just from this group's response, I just think that has a lot to do with just figuring out the time and how we appropriately allocate for that and make sure that we set our expectations and align things appropriately. My 2 cents.
And that alignment, as you indicated, Jason, with the hospital leadership to make sure that the hospital medicine team has that opportunity to participate in those leadership responsibilities. It's definitely a balance and a two-way street. Well, I think that's it, Meredith. If you want to open up for questions and answers, unless, Jason, do you have any final comments?
No, I'd be interested to hear what some questions are and what some of the folks out in cyberspace have to say.
All right. Well, thank you, Dr. Gunderson and Mark, for that presentation. At this time, if you'd like to submit a question to our panel, you can do so by raising your hand using the icon that is within the toolbox you see on your screen, or you can type the question into the available chat space. If you do raise your hand, I will call on you by unmuting you, and you will then be able to ask your question out loud. If you type it, I will read it out loud for you. And don't forget, the presentation will be available online within 1 week of today. We have a few questions already. The first one is, many specialties in healthcare have evolved into outsourced services. Is it realistic to think that traditional medical staff services may also become an opportunity for outsourcing?
I'll take my first stab at that. I think it's going to be interesting to see what happens in the next 5 years. I mean, I think the movement with healthcare reform and all the other things we talk about is going to be interesting. I mean, I think people have talked more and more about it. I mean, certainly we have hospitals that we work in where 90% of the hospitals run by physicians associated with our group. So I think that there's potential for that. I certainly think that it has some merit in terms of having a partnership that's aligned. What do you think, Mark?
Well, if I'm understanding that question correctly, I think I'm hearing it asked that where are we headed on outsourcing on the specialty side, and I think you're right pointing to healthcare reform, Jason, that the partnerships for some of the payment initiatives that a hospital will need to be prepared for, whether it's bundled payment or other types, the hospital will need to be strongly aligned with those specialties to provide the services necessary within that bundled payment. Just because the bundled payment is being offered doesn't necessarily mean the specialists are going to be interested to participate in that process. And we've certainly had our share of discussions of our outsourcing of specialists, whether that means bringing them in through a hospital medicine agreement or a contract, or in some other fashion hiring in that the specialties to within your own organization. So if I think I'm hearing that correctly, we're certainly under the understanding that the specialists represent a much needed service. We're either going to be looking for them to actively participate from the community side in some of the healthcare reform measures. And unfortunately, if we don't get that, we'll be looking to our partners such as Team Health to either help us provide that specialty service, or we'll have to go out and find it ourselves.
Thank you. Another question. With a limited number of physicians staying in-house, hospitalists are asked to take on more and more physician leadership roles, perhaps as a hospital employee or contractor separate from their hospitalist role. How can hospitalists successfully navigate this bifurcated relationship, basically being in a position where they would be serving two masters?
You want to grab that one too, Jason?
Sure. So I guess you could say that they potentially have two masters, but I think fundamentally everybody, I mean, the general direction of what these physicians are looking to do, whether they're in the hospital administration leadership role or in their hospital medicine role, is fundamentally the same. I think if we're driving, always prioritizing, our patients first. My priorities are patients, organizations, and providers, and we make sure that they're successful in that order. I think we will, everything will move in the right direction. So I don't know if I'm answering the question as correctly as I could, but I think that it's really not as much having two masters. I think it's making, if those groups are not aligned, which I think is the fundamental question, is making sure that everybody's on the same page working toward the same thing, then that becomes a moot point. If you're having conflict, which is I think one of the issues that was really a challenge in the kind of traditional private medical staff, that there seemed to be this divergence in their direction in terms of what they wanted to do. And I think that we need to make sure that we're keeping everybody on the same page. Hopefully I answered that correctly.
Sounded great to me. Yeah, thank you.
Did you want to add something?
No, go right ahead, Meredith.
Okay, next question. As a physician leader, do you feel that hospitalists should be compensated for time spent on committee, meeting, or hospital initiatives?
Oh, that comes directly to me as the doctor on the call. So, you know, it's an interesting question. I think that to a degree, there's a certain amount of good faith I think that people should do within the hospital. I mean, that's how you have to think about this from the hospital standpoint. You know, 10, 15 years ago, they didn't pay for hospitalists. They didn't pay for surgeons. They didn't pay for it. They didn't have to pay for this stuff. It was just part of the way things operate. I think that there's a certain amount that goes in towards what I consider the citizenship of the program. In other words, the parts of just being part of the organization that we do. I do think that there should be some compensation to account for, you know, time. If you're asking someone to head up the implementation of the EMR, that's not an hour of, you know, running a meeting every 4 weeks. That's lots of work. So I think that it's a thing. We have to be careful about how much we say and start trying to, you know, push for money for every little teeny tiny thing we do. But some of it's just part of being part of a community, the little bit of the give back for working together. So I think that everybody should do a little bit for citizenship, but I think that when we're getting into, you know, big projects, whether it's running QA projects or things that are really involved, we need to make sure we account for that. How we do that is important.
If I can jump in too, Jason, I just have to absolutely agree with you. Especially those projects, and we were successful in 2011 for stage 1 meaningful use, and if it wasn't for our physician champion, who happened to be our medical director here for the hospital medicine program, if it wasn't for him and as well as our staff leading that charge and helping the IT department really understand where we needed to head, we would not have been successful. It was hospital medicine physician was the first person to put an order into our system electronically. They're using the system to the greatest degree possible, and that participation in that champion role absolutely needed to be reimbursed in a completely different fashion. It was a significant project and a significant undertaking.
Thank you. So if anyone has any more questions they'd like to ask, please go ahead and either raise your hand or type them into the questions box. And we'll give a couple of seconds for those last-minute questions. A question just popped up. How can primary physicians be encouraged to become more involved with the hospital?
Well, I'll start off on that one, and I somewhat mentioned it during the presentation, and it's you know, we're still stumbling through the recognition of the evolution and where we're headed. However, the primary care physician in the community, we're starting to drive, and as Jason said, more information to them relative to the quality of the hospital stay as it relates to readmissions for some patients. We're driving to them care transition programs, trying to optimize the handoff from the acute hospital to that primary care physician in the community. And sometimes we do that extremely well, and other times we do not. And we would really appreciate that enhanced dialogue amongst especially that primary care population to how do we optimize that and how do we learn from some of the better practices within the community so that others can be lifted up to optimal performance. So we're certainly trying to modify the agenda of some of our department medical staff agendas, trying to modify those in order to kind of set that direction. It's certainly a need for the hospital, not trying to drive the agenda so that the physicians feel significantly directed, but at this point, we clearly have some sense of where our problems are and where we would like to have that medical staff leadership, and we're really looking to place that on the agenda so that there's a good opportunity for the leadership to comment. And I think if we have that strong agenda, I think that the medical staff will respond. In some respects, it's the weak agenda that causes our physicians to start to be that passive separation. They don't feel that there is a significant reason for their participation. So we certainly take significant responsibility to help drive that improvement. Jason, any comment?
No, I agree. It's really important. I think the other thing is that, when people started kind of voting with their feet and saying, well, I just want to be in the outpatient world or not have to do the inpatient side, I think it's really important, 95% of patients' health care is in the outpatient world. So I think that we really need them to have that invested interest to say, hey, this went really well, I got great information, my patient's really happy, this went super. Or to come to us from the hospital side, whether it's the hospitalist or the ER doctor or the intensivist, or to say, hey, I got my patient, that got discharged, and a bunch of these things happened, and, I'm trying to understand this better because I want to be able to, take the best possible care of them. We need them to kind of come to us and say, hey, what's up? Just as much as when they refer something in, the more that dialogue is there, the better.
Mm-hmm. Agreed.
All right, we have a few more questions. How do you visualize the collaboration between hospital medicine and emergency medicine?
Well, I will start with that one. So, one of my people that know me always laugh because I used to work a little bit on both sides of the street as an ER doc, as a moonlighting ER doc, and then, mostly as a hospitalist. But I think we have to realize that, the problems that occur within the hospital, it's not two different departments. It's one group. As a patient that comes in that is sick, that needs to be admitted and go through the hospital system, you view it as one episode of care. You don't see it as, this is my ER piece, oh, then now this is my hospital piece, or, oh, this is my intensivist piece. We really need to make sure that we are doing a couple things. I think we need to make sure that we're talking. We need to think about what work needs to be done in which environment, whether that's inpatient or outpatient, observation or inpatient, ER or on the floor, and have more dialogue about that. And we need to be thinking creatively. It can't be, oh, this is just the ER, you have to do that up on the floor. It just doesn't work. We really have to be working together. And then we have to assure that when we start to do these things, to move work along the line in the hospital, do things, is assuring quality. Because fundamentally, if the ER does a great job with someone that comes in with a ST elevation MI, and they go to the floor, and the hospital is screwed up, the whole system looks bad. So I think we need to be sitting there and talking to each other and saying, if this patient gets admitted to the floor and goes to intensive care in 24 hours, what could we have done differently? Not that it was the ER's fault or the hospitalist, but what could we, and start looking at things more collaborative relationship, because we are, the ER docs and the hospitals are pretty much the home team of the hospital. I mean, they're the ones that are there every day, because without the hospital, neither one of us would have jobs. I don't know what you think, Mark, on this.
Well, it's certainly it's certainly one of the drivers for Lodi Memorial to move to a single contracted group, and the team health was our choice, both on the emergency medicine side as well as hospital medicine. We were looking to optimize that relationship and working partnership. And while I think there's opportunities for us to continue to improve that, we're much farther along today than we have ever been with that physician groups working together in order to optimize the patient flow. So we're pretty happy with that. While we say that there certainly is opportunity, we're pretty happy with that partnership, because we absolutely see that working relationship that we have between emergency medicine and hospital medicine.
Another question, how can hospitalists navigate taking on more clinical responsibilities that fall outside of their formal training, such as head bleeds, OB patients, and neurology patients?
I think that people get very concerned about what exists in the world, the scope creep. In other words, we do this and then we slowly do more and more, and where is the line? And I think that, you know, we have to just consider when patients come in, what's the best possible situation for the patients? What can we do? How do we get the resources in the right place? And I don't know the right answer for all those. I think that when you get into those situations which are outside what people would consider the normal traditional roles, you have to put them in and make them very clear. So let me just pick head bleeds, because that was mentioned as a question. You know, that's always one that makes hospitalists really nervous, and then the neurosurgeons are, you know, look at us and say, why are you so nervous? So when you know, one of my situations, we put in a policy, we should call it blood and head policy. So we sat down with the neurosurgeons and said, what is it that you need? And they told us, you know, coverage, there's not enough of us. And I said, well, this is what we need. And I said, you know, we're not trained in this stuff. So that's a valid point. So we came up with a policy that said, you know, if someone has, you know, blood in the head, they automatically go to neurosurgery, and then we'll consult as needed. And we worked out a plan that was in the patient's best interest. And so I think as those things start to come up, you have to just think about what the fundamental question is, what the fundamental issue is for the patient, and how both specialties can work together to help each other deal with those. Obstetrical issues are the same thing. They cause a lot of anxiety, especially in our internal medicine trained hospitalists that haven't had no experience with obstetrics since medical school. You know, some of those cases are very clear medical cases and they need obstetrical consultation. Sometimes they're obstetrical cases and they need some help from medicine. Look at each one of those situations before you head down the path of doing it, and have the clinical folks talk it through, come up with a plan of how they're going to deal with each one of those, and start slow. And then you can kind of figure out how they go. I think that there's a lot of opportunities for groups to be working together and breaking these silos. That's the same thing that goes with the ER hospital medicine debate. How can we break some of those things down and make sure that everybody gets the right care to the patient? I think that there's a lot of things we can do along those. So I guess it's go slow. It's look at each individual situation as it comes up and not just say no, but think about, okay, how can we solve this problem together, and then sit down, write it all up, come up with a plan, and make sure everybody's comfortable with that plan before going into it. Most of the problems that start because someone decided all the, you know, brain bleeds are going to the hospitalist, and nobody talked to the hospitalist, and nobody did anything, and next thing you know, everybody is in panic, and it'll take you a year and a half to ever get anywhere on that topic. That was my long-winded answer, so sorry about that.
Okay, should primary physicians work as hospitalists as one way to maintain relationships with the hospital?
I'll throw that out there. Someone could say that should hospitalists work in the office once in a while so that they know what happens out there. I think that there's some value in understanding what happens in both sides of the street. However, I don't think it's there for the communication piece. I think if they're trying to have an understanding of what happens in the hospital and how it relates to what happens in the outpatient world, I think it's great for both sides to see each other's side. But you know, if you asked me to be an outpatient doctor right now, I'd be a wee bit rusty because I haven't been there. So I don't think it goes back to that, why are we all into the specialties that we are? I think we have to be clinically comfortable in doing things at a particular volume to be good at it. I think if someone comes in and out of the hospital a couple days out of the year, I don't know that there's value in that from a clinical standpoint. There might be from an understanding and a communication piece.
Well, and I'll be happy to jump in on this one. It's certainly not my practice, but I'll share the comments that I've heard from our community physician partners. It's how quickly they feel that they've lost the capabilities that they once had once they maintained that office practice and fail to exercise their hospital practice. How quickly they fall out of that that knowledge base, and how uncomfortable they would be should we ask them to come back in and practice only periodically.
There's already a shortage of hospitalists do you think the additional pressures and expectations of hospital leadership roles discourage physicians from choosing hospital medicine as a specialty?
I don't think so. I think most people, I think a lot of hospitals go into roles. I mean, they go into it for lifestyle. They go into it for various reasons, but I think they go into it for the opportunity to be working in the hospital. I think we just need, we as a specialty need to figure out how we can, improve our efficiency and stretch a little bit more. I mean, unfortunately, there's just a low supply. And I think the more we can align ourselves with our hospitals, when I do a lot of my, work with lean in different hospitals, and we figure out why productivity for the docs may be off or issues. And a lot of it is due to the fact that the relationship between the hospital and the hospitalists and the services that one group provides, i.e., CAT scans or the ability to get one might slow down what the hospitals do. I think we have to line all that together, and we really need the hospitalists to be there to help provide that guidance.
And I will add in that, today I'm looking at about 85% of our inpatient volumes being covered by our hospital medicine service. That tells me I really don't have a choice for my physician leadership. My physician leadership absolutely has to come from my hospital medicine team. They're here, they're practicing, they see the quality and the issues. We absolutely expect to see that leadership from the hospital medicine team.
Okay, well, I think that's all we have for our questions. Thank you, everyone, for participating in today's roundtable. You will receive a brief survey asking about your experience today shortly after we conclude, and any information you can provide us will be helpful in future roundtables. Please check the Practice Management Institute Online Resource Center for information on the next roundtable when it becomes available and for a recording of today's presentation. Thanks again, and have a great day.